Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today, a topic I have seen messed up so many times by both trainees and experienced attending level emergency docs and intensive care doctors, and it is the use or avoidance of the use of ketamine for the patient with severe agitation. I see so many people choosing to use this agent. At times it's inappropriate, and then when it is appropriate to use it, they use it incorrectly. And I've been planning to do this episode for a while, but then I heard the recent EMRAP piece by frenemy of the show and my buddy Reub Strayer, who did such a wonderful job of encompassing all of the ideas that were floating around my head that I'm like, I don't need to do this. I need to get Ruben to come on the show and do this. So why don't we start off with a 60-second excerpt of the actual EMRAP piece, and hopefully my buddies in EMRAP won't get pissed that I'm putting 60 seconds of their show here, and I am doing it to say how wonderful EMRAP is. So check out the whole episode if you have EMRAP, but here's 60 seconds to introduce us.
You can think of agitation in three levels of severity. There is what I call the agitated but cooperative patients who don't cause us much trouble. I'm not going to say anything else about that group. The vast majority of patients who strike an emergency clinician as agitated fall into the group I call disruptive without danger. These patients include just about everyone who comes in intoxicated or with decompensated psychiatric illness and requires calming medications, and we've been providing calming medications to these patients for decades very effectively. The classic cocktail is 5 milligrams haloperidol and 2 milligrams lorazepam, IM. You can do better than that with droperidol, midazolam, olanzapine, but you don't have to do better than that. You can carry on with 5 and 2, which takes a while to work because Ativan is poorly absorbed IM and haloperidol is slow-acting, but it's fine because these patients are disruptive, but there's no danger. There is a third group of patients with agitation, and in most departments you will see them rarely, but this is the most important group. These patients are dangerously agitated. The violence has to be controlled immediately. These patients should be treated with dissociative dose ketamine.
So there you go. The gist of this, if you don't want to listen any further, is simple. If a patient is agitated, disruptive, and dangerous, then ketamine. And if they are not dangerous, then no ketamine. I see this abused so often. Patients in acute areas of an emergency department get a ridiculously homeopathic dose or slow-acting dose of a combination of standardly Haldol and Ativan, and then they're like, screw it, that didn't work, let's give them ketamine. And then they don't get any monitoring, and they don't get any increased diligence, and most of those patients will do fine, and some of them won't. It's not the way to go. Ketamine is reserved for the dangerous patient. Now, Ruben in the piece goes on to define danger as either a danger to the staff, the team, the people around the patient, or a danger to themselves, as in they have a life-threatening condition that may actually be the cause of their encephalopathy, or maybe they're altered and disruptive from some other cause. But the point is they are preventing you from treating their life-threatening condition, and they are dangerous and they are not letting you do what you need to do. So there's your category that gets ketamine. That, what we've just gone through in the past 3 minutes, is the setup for this episode. So let's get right into it with Reub Strayer on patients who should and should not receive ketamine for their disruptive behavior. You laid out such a brilliant delineation of the three groups we need to treat in the ED with agitation. And it just, listening to that piece, and the reason I wanted you on is it just, in such beautiful language, laid out what I had as more of an inchoate paradigm in my head. And it was just perfect. And, just to reiterate, we have the agitated but cooperative, which we don't really need to do much with, right? Maybe non-pharmacologic techniques or oral medications. I mean, who do you envision in this group?
So this is like the elderly, sort of slightly agitated, confused person who is fine if you're standing there and just chatting with them. But as soon as you walk away, they get confused, they get scared. These are the folks who will take a sublingual something. These are the folks who only become a problem if they don't have a family member next to them. And it's not unimportant. It's just that it doesn't cause us too much trouble, and we don't have to spend a lot of time focused on it.
Exactly. And then group 2 was disruptive but not dangerous. And this is where I'm going to quibble with you a little bit. And I think we're on the exact same page, but I think we gave short shrift to one of the major problems I see. And so these disruptive but not dangerous patients, my residents quite often will give the standard 5 and 2. They'll give IM Haldol and IM Ativan because that's been, the industry way for years and years and years. And then, and which will be fine eventually, because as you said, they're not dangerous. Eventually they'll get there. The problem lies in the fact that people get impatient because it takes a long time. And maybe they'll give another round of standard 5 and 2. And then they're like, wow, I have nothing to do except give this patient ketamine because it's been 15 minutes and they're still requiring 3 nurses at the bedside to keep the patient from leaving or getting out of bed. And they say, fuck it, I'm going to give ketamine. And so what's your thoughts on that?
So 5 and 2 comes from the psychiatry literature over decades. And there's nothing wrong with 5 and 2, except that there's everything wrong with 5 and 2. What you're trying to accomplish with disruptive without danger patients is you want them to go to sleep. You want to do that safely and you want to do that quickly. 5 and 2 is going to be safe almost all the time. 5 milligrams of haloperidol, 2 milligrams of intramuscular lorazepam. It's going to work most of the time. It's just not going to work all the time. And it always takes forever. And although it's not a huge problem if it takes forever because there's no danger, because these folks are disruptive, they make it impossible to care for anyone else in the department while they're screaming and shouting. And so this makes docs impatient. And so they'll redose or they'll do worse things like hold them down, put someone's gloved hand over someone's mouth. And that's when you can really start running into trouble. So it would be great, even though 5 and 2 is okay, it would be great if we could just move away from it and use effective, quick-acting drugs that work much better. The best is single agent droperidol, which is back and it is available. We just got about 500 doses of it just a couple weeks ago in my shop. It's made by one company, but I think there's another company coming online. And you should be able to get this drug again. It went away for about a decade, but it's back. And 5 to 10 milligrams of intramuscular droperidol will be very safe and very effective far more quickly than haloperidol or even haloperidol and lorazepam. Let me further note that intramuscular lorazepam, IM Ativan, is very erratically, poorly absorbed and works slowly. So if you want to give a benzodiazepine intramuscularly, for sedation or for seizures or for alcohol withdrawal or for whatever, it should always be midazolam, Versed. The pharmacokinetics of intramuscular Versed are far superior to the IM pharmacokinetics of either lorazepam or diazepam. So you want to use drugs that are effective and quick IM, which is single agent droperidol, ideally. If you don't have droperidol in your shop, then you can use single agent midazolam, which is a little trickier because you'll run into respiratory depression at the doses that are reliably effective, or you can give a larger dose of haloperidol, which again, it's going to be slow acting, but then combine that with a little bit of midazolam to give you that kick up front.
Yeah. Well, you see, now you're where I am, which is I think we should be prescriptive about this. And you weren't prescriptive in the EMCrit piece. People should stop using Haldol and IM lorazepam. They are agents that do not work for the intended effect, which is just what you said. We want these patients to go to sleep. You mentioned droperidol, fantastic. You mentioned if you're going to give an IM benzodiazepine, midazolam, agreed, totally. And then you've mentioned this in other places. You didn't mention it now, but olanzapine is certainly more effective than Haldol for the desired effect. And I know you're using it. What doses are you using? And are you combining it with benzodiazepines?
So olanzapine is really close to droperidol. It seems like in all respects. It also works, for example, for headache and nausea in the same way that droperidol works for headache and nausea, and haloperidol. Just haloperidol is just slower and less effective. The dosing, I don't use olanzapine very often because I have access to droperidol, and I was using big doses of Haldol before, which I would combine with midazolam and it would work fine. But the doses are very similar to the doses that you would use with Haldol or droperidol, somewhere in between 5 to 10 IM. There's a little bit of trickiness reconstituting olanzapine. It takes a little bit more time, so your nurses have to get adjusted to that. But certainly if you don't have access to droperidol, if your options are haloperidol or olanzapine is probably a better choice.
All right. So now let's get to the crux, the disruptive and dangerous. And you put a dividing line that was just brilliant as the arbiter for who really deserves to be in this category. And it is that the patient would be intubated or would potentially be intubated if ketamine was not available. So the patients who are in so much danger to either the staff themselves, whether it be because of the agitation itself or their underlying condition, that in the past we might have RSI'd these patients to take control. Those are the patients who you would give ketamine to. Is that a fair rendition?
Yeah, so that's what I call the ketamine litmus test in terms of who to tranquilize with ketamine. Since I started talking about ketamine for sedation, for tranquilization many years ago, people have started using it more and more, which is fine when it's used appropriately. The problem with ketamine for tranquilization is that when you use ketamine in a dissociative dose in a person who is not intubated, that person requires PSA level monitoring for the duration of their dissociation, meaning that you have likely a nurse and a physician standing there at bedside continuously, which is not where you want to be on someone who is merely disruptive, but where there's no danger. If there is danger, either because the patient is so agitated, they are severely agitated and they pose an immediate threat to themselves or others because of their agitation, or you're concerned that there may be an underlying dangerous condition like a brain bleed or hypoxia, in those cases, you need to take immediate control. And so it's appropriate to provide high-level, vigilant resuscitation type monitoring for those patients because the patient is a resus patient because there's so much danger, but not a routine agitated drunk. That is a person that you want to go the fuck to sleep. Put them in a corner and let them wake up, shake it off, reassess them and let them go home, maybe give them a little bit of a guidance about their problematic drug or alcohol use, try to set them on a better course. But the point, the purpose with the disruptive without danger patient is to safely get them to sleep. The point with the patients who have a dangerous condition or are dangerously, violently, severely agitated is to take immediate control. Those are separate goals. And so you want to use a separate, distinct strategy for each.
Absolutely. Perfect. Now, let's talk about the logistics of this. Some departments, the one at Janus General included, have security staff, have the new variant of leather restraints, which once a patient's in them, they are far, far less dangerous. And we now have agents like droperidol back. What would be the dividing line from a patient? And you touched on this in the EMCrit piece, that the resources of the location determine the necessity for whether the patient is dangerous enough to require ketamine. But even more from a sociological standpoint, do you think it's better to give IM ketamine, or do you think it's better to tie a patient down and then wait the 3 minutes for the droperidol to take effect?
Well, I would offer a third option. So on the first point, what is uncontrollable? So the phrase I use is uncontrollably violent. And what's uncontrollable depends entirely on what your resources are. So if you have a bunch of huge guys waiting in your security wing to hold down someone, or even just as a huge show of force, that often does the trick as well, it's going to require a lot more uncontrollability, a lot more agitation, a lot more violence to be deemed uncontrollable in your environment than if it's just you and your partner in the back of a rig in an alleyway, which is why, as I mentioned in the other piece, we see so much of the ketamine for tranquilization literature coming out of EMS, because when it's just the two of you in the back of a rig with a patient who's getting progressively agitated, that patient is going to become uncontrollable by you and your partner much more quickly than the same agitated patient when there's a dozen security officers around. So the dividing line for uncontrollable always depends on your environment. So the third option that I would pursue is to hold that patient down, deliver your intramuscular shot of a quick-acting effective agent, and then stand there, hold them down, and then they will calm. And they will calm with an appropriate shot of droperidol, midazolam. They will calm within minutes. About the same amount of time it takes to properly apply restraints. And applying restraints is a brutal, really shitty thing to do to someone. Most of these patients are not in their right mind, either from intoxication or psychiatry. And the unfortunate reality is that a lot of the tradition around tying people up, comes from what I think is a sadistic impulse to teach them a lesson, because they're cursing at us, they're spitting at us, and they're making us angry. And we're being led by our maladaptive, violent instincts, which we need to rise above because we're supposed to be professionals here.
No one talks about this, and I wasn't planning on talking about it, but now you bring it up. No one has really given us the safest way to give these patients IM injections when they're flailing about. You kind of just have to sneak in there at the right body part and hope that at that exact moment the patient doesn't flail or thrust out their leg or arm. Do you have any tips for that, Reub?
Mm-hmm. So the first element in tranquilizing a dangerously agitated, severely agitated patient is to approach that patient with adequate force. Now, in the moderately agitated patient, that's the patient where the nurse can kind of sneak up on the patient and work their magic quietly, sort of giving that IM shot without the patient barely noticing it. The dangerously agitated patient is a different story. That person needs to be approached with overwhelming force. And that means a big group of people, ideally one person for each limb and one person for the head. That does not include the physician orchestrating the scenario, and does not include the nurse who is providing the medication. The tips around giving that medication are a couple. The first is that it needs to be done IM. I just want to make sure we focus on that. It should never be the case that someone is being held down with a lot of force while someone else, a nurse or someone else, is trying to get a line on that patient for a number of reasons. First, because getting a line on a thrashing patient takes time, and that's time that's much better spent watching the patient calm down after an IM shot. Secondly, you put your providers at risk for a needle stick. Once you give that IM shot, an effective IM shot, the patient is going to calm down, and then you can get all the lines and all the monitoring that you need. When you have a big, strong person on each limb and another strong person on the head, and ideally you also have an oxygen-providing face mask on the patient's mouth and nose to provide oxygen and to control that patient's spit, you then approach the patient and inject that patient, ideally with a single injection, which can be up to 20 cc's at variance with many nursing protocols, which only allow, in many cases, for up to 5 cc's IM. That is total nonsense. I have lots of literature to support you if you want to try to overcome that frequent nursing protocol. You can give up to 20 cc's IM. Certainly, you can give 10 cc's of 50 per cc ketamine. And you want to give that into either a deltoid or the lateral thigh through the clothing. Do not try to take off the clothing. Do not try to remove any clothing. You give that intramuscular injection through the patient's clothes, and there's actually literature to support that as well.
All right. Fantastic. As usual, I get far more answer than I could have expected. It's excellent.
Now, if you want to try subdissociative ketamine, then you are sort of in no man's land. And I want to spend a moment talking about that, because people have a misunderstanding about how ketamine works as it pertains to agitation in particular. If you give a very small dose of ketamine, say 10 milligrams IV in a normal-sized, normally perfused adult, then you're going to have almost no psychoperceptual effects. You're going to be in what I call the analgesic dose range, and that's great. If you give a dissociative dose to a normal-sized, normally perfused adult, say 100 milligrams, you are intravenously, you're going to affect dissociation very reliably. And that's great, because we all know where we are with dissociation. If you double that dose and you give 200 milligrams, you are still going to be dissociated. You're not going to have much more effect, except for a longer duration of action. But once you exceed the threshold of dissociation, you don't really get further physiologic effects. You just prolong the duration of action, which is a neat feature of ketamine and lends it a very wide therapeutic index. The problem is that in between the analgesic dose of ketamine and the dissociative dose of ketamine, you don't really know what you're going to get. I've identified what I call the recreational range, which is something like 30 milligrams, 40 milligrams IV in a normal-sized adult. In the recreational range, folks who get that kind of dosing are loopy, they're hallucinating, but they know what's going on. They can walk around, They can talk to you. They can say things like, whoa, this is really, really weird. What did you just give me? The walls are throbbing. And that can be unpleasant for some people. Some people will love it. In fact, ketamine is used recreationally for this purpose. But many people will be a little bit distressed by it. They don't want to see the walls moving. They don't want to feel their hands coming off of their bodies. But you can talk to them. You can reassure them. You can tell them you're in the hospital. Everything is fine. You just got a very powerful drug, but you're going to come back to normal in a few minutes. Or you can just give them a milligram or 2 of midazolam or whatever, and it's fine. The problem is that if you push the dose further, but not past the point of dissociation, you end up in what I call partial dissociation. And that person is disconnected from their mind, from their body, from reality, but they're not yet unconscious. They're still conscious. So they're awake. They can't speak properly. They may not be able to move. They have no idea what's going on. They may not be able to hear you. And this is where we see the so-called emergence reactions that are unfortunately not that uncommon as someone emerges from procedural sedation. The reason that we don't see them when you're giving procedural sedation is that you give a dissociative dose. Let's say you give 150 milligrams IV, you immediately bypass the analgesic, recreational, and partially dissociated phases of the ketamine brain continuum, and you push that patient immediately into dissociation. But you cannot prevent the patient from going back through those phases as they metabolize the ketamine on emergence, which is why psychiatric distress occurs on emergence. The problem with using small dose ketamine for an agitated patient that you just want to calm down is that if you give a subdissociative dose, not completely dissociated, but not tiny like an analgesic dose, you may calm the patient. You may whack them on the head with 50 milligrams of ketamine that may not dissociate them. It may just partially dissociate them. They may be in a recreational zone where they're kind of looking around and being like, whoa, this is really cool. It may calm them down, and that's fine. You can get away with it sometimes, but you may not calm them down. You may make things worse, in which case you need to either give a conventional titratable sedative to calm them from the agitation they're now getting from being partially dissociated, or you may need to augment that partial dissociation dose of ketamine with more ketamine to push them past the threshold of dissociation, in which case you're now, again, requiring PSA level monitoring, which in a routine agitated drunk is a fail. You don't want to be providing PSA level monitoring to your routine agitated drunk, which is why using small dose ketamine, subdissociative ketamine, on a routine agitated drunk is not a good idea. The routine agitated drunk is where you use a conventional titratable sedative.
Fantastic. Anything else we need to hit, or have we hit it all?
No, I think that mostly covers it. Just keep your eye on the ketamine brain continuum. If you understand how ketamine works across its dose response curve, you'll be well positioned to use it for all of its indication.
Fantastic. Can't thank you enough for coming on, Reub.
Always a pleasure, Scott.
So there you have it, folks. Please stop giving ketamine to patients that aren't dangerous. Do give ketamine at the right dose to patients who are. You can find all sorts of references, additional information, etc. at emcrit.org/279. Until next time, this has been Scott Weingart for the EMCrit podcast saying bye-bye. All physician CME for the EMCrit podcast is provided by EMPractice, publishing the best evidence-based emergency medicine literature out there. You could check out their wares at ebmedicine.net/EMCrit.